Welcome to the Boston Medical Library's 50th annual Garland Lecture. I think. Yeah. I'm Rick Peters, president of the Boston Medical Library. This lecture is being taped and will be posted on our website, events page at bml.org. The BML is committed to providing library services and lifelong learning opportunities for physicians and dentists in Massachusetts. Please visit our website, bml.org, to learn of our library services provided by a contract with the Lamar Suter Library at UMass Chan Medical School. And please consider becoming a fellow of the Boston Medical Library. 2025 is also the 150th anniversary of the founding of the Boston Medical Library. A celebration of this momentous occasion will be held Friday, November 7th, also in this building and on Zoom. Please plan to join us for this event as well. Help, please. The Garland Lecture is named in memory of Dr. Joseph Garland, the 13th president of the Boston Medical Library and a former editor of the New England Journal of Medicine. The Garland Lecture has been one of the proud traditions of the BML since 1976. I want to express my gratitude to the members of the Garland Lecture Committee for their role in planning this lecture. This lecture is approved for 1.5 CME credits, available if you respond to the evaluation survey, which will be sent to you shortly. Our speaker tonight is an old friend. He's a life fellow of the Boston Medical Library. Many of you will remember him from his time as Speaker of the Massachusetts Medical Society House of Delegates. Very early in his career, he was recognized as a leader in medicine. He was a recipient of the 2008 AMA Foundation Leadership Award. In 2023, he became the 178th president of the American Medical Association. Only 4 Massachusetts physicians have received this honor, including such medical luminaries as Henry Ingersoll Bowditch, one of the founders of the Boston Medical Library, and John Collins Warren. Jesse is a tenured professor of anesthesiology and clinical informatics, senior associate dean at the Medical College of Wisconsin, and executive director of the Advancing a Healthier Wisconsin Endowment. His research focuses in 2 areas. First, how can we leverage technology to improve learning and practice and reduce health disparities? And second, how information technology can more effectively protect patients from harm and impact processes of care within acute care environments. Tonight, we have the privilege of hearing his thoughts on the transformation of healthcare and historic perspective on what's to come for American medicine. Jesse?
Thank you very, very much for that very kind introduction, and thank you for inviting me to be here tonight. It's nice to come back home since I did live here for 10 years. It really is a profound honor to be giving not just the Garland Lecture, but the 50th Garland Lecture, a lecture graced by really so many notable leaders over the last 5 decades, leaders in the field of medicine. And for many years, I've been a fellow of the BML. And while my professional home is currently in beautiful Milwaukee, Wisconsin, the BML's origins and my connection to it remain very personal and very structural. So as many of you know, the BML was reconstituted in 1875 with Dr. Oliver Wendell Holmes Sr. as its president. Dr. Holmes was not just a brilliant physician. He was a celebrated poet and an acclaimed essayist. someone whose foresight really extended well beyond the clinic and into the heart of our nation's civic life. And probably his most famous written work, Old Ironsides, which was published in 1830, was an impassioned poetic defense that was incredibly influential in preserving the USS Constitution, still the United States Navy's oldest vessel still afloat. Now, why does that matter to us tonight? Well, you see, Dr. Holmes was a graduate of Phillips Academy in 1825. 176 years later, I found myself studying biology, developing a love for the sciences, and having my first inkling of a desire to become a physician, all within the walls of the Oliver Wendell Holmes Library at Phillips Academy in Andover, Massachusetts. And on a final note of structural legacy, I also had the distinct honor of receiving my commission as a U.S. naval officer aboard the USS Constitution, Old Ironsides, in 2008. So that lineage, this connection to a physician whose passion was not just healing the body, but preserving the foundational structures of our national identity, really reminds me that the work of medicine is about the work fundamentally of stewardship. It's more than just about treating today's symptoms. It's about safeguarding the future integrity of the system itself. So as I stand before you this evening, I'm reminded of the first time I walked into an operating room, not as a physician, but as a college student in Philadelphia through a shadowing program. I was curious, definitely nervous, very unsure. And that moment sparked a journey that has taken me from the exacting discipline of clinical practice to the broad canvas of policy, advocacy, from the quiet intensity of academic medicine to the tumultuous front lines of healthcare innovation. And along the way, I've definitely seen firsthand how medicine evolves, not just through the spectacular breakthroughs in science, but through the systems, the values, the strategic decisions that shape how and for whom care is not delivered. So we're all familiar with the quote, I'm sure on the bottom of the slide, the enduring wisdom of Sir William Osler, who wrote that the good physician treats the disease, the great physician treats the patient who has the disease. And Osler's wisdom is more than a simple maximum. It's a philosophical grounding for the entire discussion that I hope we have tonight. It reminds us all that even as medicine rapidly evolves into a domain of data science and machine learning, that the heart of care must remain unchanged. It forces us to confront the tension between high tech and high touch. And our collective transformation in healthcare must remain grounded in this essential human connection. No matter how advanced the tools get, no matter how fast the processors, how smart the algorithms, the essence of care is still in the reciprocal, trusting relationship between the doctor and the patient. You know, if we think back to 2019 and 2020 and the rapid rise of telemedicine during the COVID-19 pandemic, virtual visits expanded access, but the most successful implementations, and we've seen this because these implementations are enduring, were not the ones with the best video resolution. They were the ones that preserved empathy, where clinicians still had time to look past the screen and ask about the family, understand the context, address concerns, not just symptoms. And the technology amplified the care, but it didn't replace the physician, the caregiver. So this evening, we're all gathered here in person and online at a pivotal moment. The pace of change in healthcare is accelerating. It's driven by exponential advances in technology, challenged by fragmented policy, and shaped by the strategic choices that we make as a community of leaders. But to understand where we're going on this journey ahead, we have to first understand where we've been. The art of medicine has long been shrouded in tradition, but the future of medicine, I believe, is going to be shaped by data, design, and daring. And this is the lens through which I view our next chapter. The era of the quadruple aim, improving patient experience, the health of the population, the communities that we serve, lowering the cost of care, and importantly, improving the work life of healthcare practitioners and physicians. We're entering an era where bold thinking, thoughtful system design, and intelligent use of data will all redefine how we deliver care. And critically, who gets to benefit from it? That has profound implications for the future of the profession, the health of our nation, and our collective ability to address emerging challenges with innovative, sustainable solutions. Just look at ambient AI documentation tools that are being rapidly deployed across health systems. These tools don't just automate a task. They help us reimagine the clinical encounter. They're quite literally giving physicians back their time, freeing them to focus on the patient while the technology handles the charting seamlessly in the background. That is design and daring in action, and that is the direction we have to pursue with intent. We're at this pivotal crossroads where the wisdom of our medical heritage is meeting the promise of unprecedented technological advancement. Understanding where we've been illuminates the path forward, revealing patterns of innovation, ethical challenges, and I think gives us focus that we desperately need from our enduring commitment to healing that defines the profession. So in the hour or so that we've got together, I'd like to explore how innovation and policy and strategy have continued to transform American medicine. And I'll sort of walk through and discuss the forces that are reshaping American medicine through both a historical context and a forward-looking analysis. And I'll look at some of the breakthroughs that really changed everything, some of the missteps that have taught us hard truths, and what I think are immense opportunities that lie ahead if, and only if, we're bold enough to seize them with integrity and foresight. So I want to start by examining the deep roots of our current system. To understand where American medicine is headed, we have to first examine the inflection points that brought us here today. Each milestone in our shared collective healthcare history reflects a dynamic tension between access and cost, innovation and equity, quality and sustainability. The present day challenges that we all have and share together really can be traced back to the results of decisions made a century ago. And each milestone that brought us progress also brought us unintended consequences, creating this very complex landscape that we and our patients now have to navigate. And these historical turning points really, I think, reveal these recurring tensions between standardization and practice variability. access and quality, innovation, and equity. So let's begin in 1910 with the Flexner Report, a landmark study funded by the Carnegie Foundation, intended to standardize medical education. Its outcome, we all know, the closure of numerous substandard proprietary schools and the establishment of rigorous science-based academic standards. That report and the work of Flexner professionalized American medicine. It cemented the hospital university model that we still, in large part, use today. But the progress was Janus-faced, promise and peril at the same time. The report effectively moved medical education forward, but it narrowed the pipeline. It emphasized large endowments and university affiliations, and it disproportionately targeted and led to the closure of many historically Black medical colleges and the closure of institutions that primarily trained women and low-income students. The immediate effect was a drastic, decades-long decline in the number of Black and female physicians. We still feel the impact of this today. And the legacy of Flexner echoes in debates about diversity in medicine, resource allocation in medical education, and the structural inequities that are baked into the system. So I think of the report as a really critical reminder that progress often comes with unforeseen, inequitable consequences, if not meticulously guided by principles of inclusion. This period continues with some scientific triumphs that really redefined mortality itself. In 1928, you know the story, Alexander Fleming observed this mold, Penicillium notatum, had killed bacteria in a petri dish that he had accidentally left out. And that discovery of penicillin by Dr. Fleming ushered in the antibiotic era, dramatically reducing mortality from previously fatal infections, fundamentally changing the practice of surgery and trauma care, and the subsequent mass production of antibiotics transformed both civilian health and, importantly, wartime medicine, especially during World War II. After World War II, America invested heavily in the infrastructure of care. In 1946, the Hill-Burton Act funded the construction of thousands of hospitals and health centers across the country, especially in underserved and rural areas. This act successfully expanded access to care and laid the physical foundation for modern healthcare delivery. However, by subsidizing physical facilities without equally robust planning for physician recruitment and long-term operating costs, it also reinforced the geographical disparities that still exist today, where facilities exist, but specialty access and primary care access remain scarce. Okay, the next era is this era of entitlement and complexity. In 1955, the approval and subsequent mass rollout of the polio vaccine marked a major public health victory. It demonstrated the unparalleled power of coordinated scientific research, government funding, and public trust in collective action. It showed a time when public health was viewed as a unifying rather than a divisive goal. Then the most profound structural shift came in 1965 with the signing of Medicare and Medicaid. And these programs expanded access to care for elderly and low-income populations, cementing healthcare as a social good to be protected by the state. The political triumph introduced federal oversight, however, into the healthcare system and established a completely new era of complexity. The need to process claims, the need to manage budgets for tens of millions of people introduced billing codes, utilization review, reimbursement rules, layers of regulatory oversight that still define how care is delivered and financed today. The unintended consequence was the birth of the payer, provider, patient triangle, where the payer, either government or insurer, dictates the terms of the interaction. And then the focus pivoted from expansion with Hill-Burton, Medicare, Medicaid, to containment. And in 1983, the introduction of diagnosis-related groups, or DRGs, completely transformed hospital reimbursement for Medicare. Instead of traditional fee-for-service, paying for everything rendered, regardless of necessity, Medicare began paying a fixed amount based on the patient's diagnosis. This was a pivotal moment. It introduced the concept of incentivized efficiency and cost management into the core of hospital operations. And while this definitely successfully curbed some runaway costs, it also sparked immediate concerns about things like premature patient discharge, upcoding, potential undertreatment to maximize profit margins. And it marked the definitive beginning of the shift towards cost containment and performance metrics. This period is kind of capped by the 1906 passage of EMTALA, Emergency Medical Treatment Active Labor Act, the goal to ensure emergency care access occurred regardless of a patient's ability to pay. And while EMTALA is an important, critical, moral, ethical safeguard, it's placed a significant financial strain on hospitals, particularly our safety net institutions, by mandating services that were often not compensated. And what this did is effectively transferred the financial burden of the coverage gap that still exists onto the provider system. Okay, we now get to the current day and the digital transformation and policy battles that are playing out. The path to the modern era really was forged through the digitization of data. In 1996, HIPAA, Health Insurance Portability Accountability Act, really laid the foundational groundwork for data privacy and the security protocols necessary for electronic health records. HIPAA really was a necessary response to growing concerns about confidentiality in an increasingly connected and interconnected world. But this necessary security also introduced monumental administrative burdens and compliance challenges that we still wrestle with as physicians, often feeling that the privacy rules inhibit the fluid sharing of information that's really necessary for optimal care coordination. Also in this era, we see things like the completion of the Human Genome Project in 2003, opening the door to precision medicine, allowing for exponentially more personalized approaches to diagnosis and treatment. That really, I think, in my mind, represents a scientific event that promised to fundamentally individualize care, moving beyond the population level averages that we historically have used. The next technological mandate in this period came in 2009 with the HITECH Act. This legislation aggressively, probably somewhat inappropriately, prematurely, incentivized the adoption of electronic health records, accelerating the digitization of clinical documentation. Now, it succeeded in making the EHR ubiquitous. Everybody got their incentive payments and took your tax dollars. But critically, without adequate focus on usability, interoperability. The result was a massive increase in physician frustration, pain, and burnout. The number one dissatisfier for 10 years running was the electronic health record. It's now number two, prior auth number one. Clinicians, and you can see this in the data, increasingly felt alienated from their patients, spending more time interacting with the screen than with the person in front of them. The EHR was always meant to be a tool, but it has become a third party in the exam room, driving, I think, a crisis of professional meaning that we see today. And then the political culmination, I think, of the modern era really was the 2010 passage of the Affordable Care Act, aimed to expand coverage to millions, had goals to promote value-based care and accelerate health IT adoption. ACA sparked, as we all know, and have lived through, fierce political and ideological debates. And that's important because it has to remind us that healthcare is not just a technical or an economic issue. It is a deeply human, moral, philosophical one that touches the core of our citizenship. And the ACA was and remains today a policy of ambitious structural change that forever changed the market and the regulatory landscape. And then finally, we get to COVID in 2020, this pandemic that showed us all the critical vulnerabilities in our fragmented health and public health infrastructure. COVID demonstrated the catastrophic failure of non-interoperable data systems to communicate in a crisis. We all lived through it. It accelerated that telehealth adoption out of necessity, forcing regulators to temporarily waive archaic rules. More importantly, it really forced this national reckoning with health equity, demonstrating clearly that social determinants of health, housing, employment, food access, were the primary vectors for disease and mortality disparities. And that crisis, I think in some ways, has been a painful catalyst for change. So throughout healthcare's evolution in the US, there are four interconnected priorities that continually compete for attention and resources. And optimizing any one dimension often is creating trade-offs with others, requiring very difficult decisions about values and priorities. And every transformation in healthcare, including the ones that I just kind of walked through, reflects this dynamic tension between access, quality, cost, and innovation. And the structural challenges that we all face today, burnout, equity gaps, cost inflation, are the unintended consequences of yesterday's necessary progress. And so navigating all these tensions with intentionality is the essential work of leadership. So if history teaches us anything, it's that technology has always been a catalyst for change in medicine. But technology alone has never been the solution. Today, we are witnessing the emergence of true intelligence within our systems, a shift that is challenging us to redefine the very nature of clinical work. We've gone from mechanization to augmentation. Let me review that trajectory. So in the past, we had the mechanization of things. Innovations like the X-ray, the MRI, robotic surgery, focused on mechanizing physical tasks or revealing hidden anatomical structures. They introduced high capital costs, new training complexities, but the core of clinical decision-making was untouched. Today, we are in an era of augmentation. Artificial intelligence is not theoretical. It is an active agent in our clinics, our workflows, and our decision-making. The most immediate and impactful transformation occurring at the point of care, I already referenced it, ambient documentation. Tools from dozens of companies are using large language models to listen to natural conversation between the patient and the physician, transcribe it, structure it, generate a fully coded, compliant clinical note. And, I don't practice primary care, but if I did, and I was seeing a very complex patient with chronic conditions, type 2 diabetes, hypertension, heart failure, new depression, in a pre-AI world, a 20-minute encounter would require me to spend another 15 minutes after the patient left, reviewing the notes, navigating the labyrinth of the EHR interface, searching for ICD-10 codes, finalizing the note. That pajama time, the primary driver of clinician burnout. In an environment where ambient AI has been deployed, the interaction is much more natural. You can maintain continuous eye contact with your patient. You can ask not just about blood sugar, but about the patient's grandkids, the recent loss of their spouse, their difficulty affording fresh produce. And the AI hears those keywords: grandchildren, loss of spouse, a potential social determinant of health, difficulty affording fresh food, a food security issue. When the visit concludes, the physician can briefly review a structured draft note generated in real time that includes the objective clinical data, vitals, glucose readings, medication changes, an assessment and plan with structured medical decisions, social context, capturing the food insecurity, the recent bereavement, automatically generating referrals to relevant social workers or community resources. And then in 60 seconds, the physician can validate the note instead of spending 15 minutes typing it. And the result is not just saved time, but a richer, more humanistic clinical experience for both the physician and the patient, while also ensuring that the documentation captures the complexity necessary for appropriate population health management and reimbursement. That is the quadruple aim in action: better experience, better documentation, making it less burdensome for the physician involved. Now, while the power of AI to improve efficiency is undeniable, the promise of its benefit has to be matched by a commitment to ethics, transparency, and inclusion. And we have to confront the reality that AI is not a neutral technology. It is a mirror reflecting the data it's trained on. And the most critical challenge for us is algorithmic bias. If an AI model is trained on data predominantly drawn from affluent, white, male people, which is what our historic data sets typically reflect, it will necessarily perform worse or even dangerously when deployed on diverse patient populations. A prominent example, well described in the lay literature, involves risk scoring algorithms used by many major hospital systems. These algorithms were designed to predict which patients are at high risk for future poor health outcomes. The idea is that you then allow health systems to proactively assign them to more intensive care management programs. But it turns out that one widely used commercial algorithm systematically assigned Black patients to a lower risk score than white patients who were objectively sicker and requiring the same amount of care. Why were those Black patients singled out for less intensive resources? Well, the algorithm wasn't trained to predict illness itself, but to predict future healthcare spending. And since historically Black patients have faced systematic barriers to accessing healthcare, resulting in lower overall historic spending, the algorithm mistakenly interpreted lower spending as lower risk. And the consequences was, sadly, that sicker Black patients were less likely, and still are less likely, to be enrolled in the necessary care management programs, perpetuating and accelerating health disparities. So how do we combat this? We have to have rigorous governance, AI audits, auditing clinical algorithms to verify the fairness and performance across different demographics before deployment and after deployment to account for problems associated with model drift. I was speaking with an AI developer yesterday, one of the leading, probably largest clinical AI companies in the world. And he told me that their models drift and degrade about 10% every 18 months, which makes them completely useless, which means that if you don't continuously audit and update your models, you are bound to have problems. The second thing we have to do is have transparency. This has to be a foundational principle in the development and deployment of AI in healthcare. I should never walk into an operating room, I'm an anesthesiologist, by the way, turn on a ventilator and not know that there's an AI algorithm operating in the background trying to optimize my inflation pressures or my tidal volumes. The only way I can step in and be the last thing between my patient and catastrophe, the human in the loop, is if I know that there's an algorithm operating that I can supervise, manage, correct, and turn off if something happens inappropriately. Third, we've got to have oversight. And we've got to ensure that algorithms augment rather than replace clinical judgment, and that their use aligns with principles that we hold so dear, starting with do no harm. Now, if we're to look ahead, the future of healthcare is going to be shaped by concepts that are rapidly moving from really science fiction to clinical reality. Things like digital twins and personalized medicine. And a digital twin, if you're not familiar with the concept, is a virtual high-fidelity replica of a patient's biological, physiological, contextual data. And the twin can model everything from molecular interactions to whole organ function. And there are platforms, several of them, that have already emerged that exist today that are modeling cardiac anatomy to do things like guide complex ablation procedures. And in the future, we expect that digital twins could allow a physician to simulate a drug trial, test the efficacy and side effects of a new chemotherapy agent on the twin before you actually administer it to the real patient, so that you can accelerate how we personalize oncology care. We think these twins will allow us to predict disease progression by running simulations to determine the optimal time for a complex surgery or another intervention, moving from reactive to proactive care. And finally, we think that there's an opportunity in the future with the digital twin to analyze environmental factors, to integrate real-time data, things like pollution sensors, daily activity logs, to model the impact of a patient's external environment on their internal biology. Now, I've talked about ambient dictation. There's also, I think, rapidly approaching this concept of ambient intelligence in clinical workflows. So beyond documentation, ambient intelligence is where you have a silent partner across all care settings. Imagine you're in an operating room and there are sensors detecting subtle shifts in the patient's physiology and instantaneously cross-reference those against the surgeon's fatigue level, historical complication rates, equipment status, to provide a silent predictive warning to the care team. That requires seamless integration of data streams, a feat that can only be achieved through policy and standards. The last example of what's ahead, today, the largest clinical AI company in the world, which has more than 20 FDA clearances, is now providing always-on instant triage capabilities for almost any image. Their software automatically triages and prioritizes imaging results. It coordinates across specialties and reduces delays. And it's improving clinical quality, demonstrated in study after study after study. It's improving patient outcomes in nearly 2,000 hospitals today by instantly activating stroke protocols, response teams, cath labs as soon as the image comes off the scanner, where minutes matter. But technology can't by itself transform healthcare. Thoughtful policy, strategic payment reform, clinical leadership, physician leadership are essential to ensure innovation serves the public good. And our governance structures have to evolve as rapidly as the technologies that they oversee, balancing innovation with safety, efficacy with equity, progress with accountability. And I think the key insight here really is that technology can amplify our humanity or it can erode it. And the difference really lies in how we design and deploy and, importantly, govern it. And I think the physician of the future has to be as fluent in the ethics of code and AI as they are in the language of biochemistry. So technology may drive the engine of transformation, but policy determines the trajectory. And that's a lesson I really learned in my role at the AMA as president. And throughout history, we've seen how regulation and reimbursement and governance have shaped not just what's possible in healthcare, but what's sustainable, what's ethical, and what's equitable. So this decade-long, very gradual transition from fee-for-service to value-based care is probably the most single important strategic shift in American medicine. So we're on our way from paying for volume, the number of things we do, the number of visits, the number of tests, the number of procedures, which fundamentally rewards inefficiency, discourages coordination, to a value-based care era where you reshape the incentives by paying for outcomes, efficiency, and quality. And the mechanics of this shift, they're complicated, but they really fundamentally demand strategic leadership. So, accountable care organizations, bringing providers and hospitals together to take shared responsibility for the quality and cost of care for an assigned group of patients, allows groups, ACOs, to share in the savings if they save money while hitting quality targets. But if they spend too much, they share in the loss. One important tool. The second is bundled payments. Single fixed payment for an entire episode of care. I know there's someone in the audience who had their shoulder worked on recently. Forcing physicians, physical therapists, other intermediaries to coordinate care across the continuum, from the office to post-acute. And then capitation, having a fixed amount per patient per month, regardless of what they get. That puts providers, physicians, systems fully at risk, incentivizing proactive wellness, prevention, and often aggressive management of chronic diseases to keep patients out of the hospital. So we've got those tools. We're familiar with them. Some of us live with them or work in those models. But the challenge of value-based care is the difficulty in measuring value in complex chronic care. How do you quantify my work taking extra time to get somebody safe housing if they have uncontrolled hypertension? the metrics have to move beyond simply reducing cost to measuring true health and true health equity gains. And we're not there, but we need policy that can enable the financing of social determinants of health so that healthcare dollars can pay for services like nutritional coaching, transportation, and home-based care. Now, there's also the imperative of interoperability. And the inability of disparate health systems to talk to one another has been the silent killer of efficiency and coordination of poor outcomes. The lack of interoperability, secure, consistent, meaningful exchange of electronic health record has created this environment of information blocking that just frustrates everybody and harms patients. And we finally started to move to address this through some landmark technology policy at the federal level. There's the 21st Century Cures Act that was passed in 2016, mandated a nationwide effort to achieve interoperability by notably prohibiting information blocking, the practice by which practices or health IT vendors knowingly interfere with the access, exchange, or use of electronic health information. 21st Century Cures did a lot, but it was really the first legal strike against proprietary systems that hold patient data hostage. FHIR, the Fast Healthcare Interoperability Resource, which was mandated by Cures, is the modern foundational standard for data exchange. You can think of it as kind of the internet protocol like HTTP for health data. And it uses these modular components called resources, patient records, lab values, medications that can be easily accessed via modern APIs. What that does is it moves us beyond simply transferring large static documents like a giant PDF to achieving data liquidity, where discrete data points can be searched, integrated, and used in real time by different applications. And then the last piece here is TEFCA, which is the Trusted Exchange Framework and Common Agreement. It's a national infrastructure. Think of it as the digital plumbing designed to create unified, secure, standardized approaches to health data exchange at a federal level. It establishes these qualified health information networks that act as trusted brokers, ensuring patient data can flow seamlessly and securely across state lines and disparate electronic health records. So together, those three initiatives, Cures, FHIR, and TEFCA, are really strategically building the digital backbone that is necessary, critical infrastructure for the future. Without that shared infrastructure, AI-first hospitals, advanced population health management are impossible. So, as a physician who trained in digital health here in Boston, informatics, I had the privilege of leading national health policy efforts at the AMA. I've seen how innovation and advocacy really go hand in hand. So, technology without governance is chaos. Policy without clinical insight is called inertia. And my journey from the operating room to the White House taught me that physicians have to redefine our leadership role. We can't afford to be consumers of technology or passive reactors to policy. We have to become the architects of care, the physician strategist. And I really think that there is a new mandate for physician leadership. We've got to be the stewards of ethical AI, leading the AI ethics boards, demanding transparency, ensuring that algorithms are designed to reduce, not perpetuate health disparities. We've got to be the champions of data literacy, not just for us, but for our teams and for our patients. Understanding the integrity of the data stream is now as essential as understanding the pharmacology of the drugs we prescribe. We've got to advocate for human-centered design. We've got to push back against poorly designed, burnout-inducing technology. We've got to co-design the tools that we use, ensuring that they prioritize empathy and restore the joy of practicing medicine. And then we also have to be the strategist of value, guiding that shift to value-based care by identifying and quantifying the true drivers of health in our community, moving policy discussions beyond simple cost control. This is not just work for the chief medical officer. It's got to be the work of every resident, every attending, every clinical leader. The future that we imagine has to be built both on insight and integrity. So what's to come? If the past has taught us anything, it's that transformation in healthcare is never linear. It's shaped by technology and policy, and importantly, the intentional choices that we make. So I'm going to give you three, because we're running short on time, plausible, but not inevitable scenarios for American medicine by 2030. And I'll talk through the strategic demands that each one presents. Okay. Don't worry if you can't read any of that. That's fine. The first is the hyper-efficient AI-first hospital system. This is a future where the promise of automation is fully realized, resulting in a dramatic change in hospital staffing and function. The operational model here, right? Revenue cycle is totally automated. Billing, coding, prior auth, claims entirely managed by intelligent automation. Payer rules are ingested, applied instantly, eliminating most of the financial administrative staff. They're all gone. Denials are predicted and prevented. You've got intelligent triage and logistics. AI-driven triage tools assess patients via virtual portals or upon arrival. They assign acuity. They generate a preliminary differential. They order basic labs before a human sees the patient. Optimizing staff allocation in real time. Emergency departments run smoothly, and wait times are minimized. Staff get redefined. The traditional support roles, scribes, most of the coders, many administrative assistants, they're all replaced by machines. But there's a new role and a new set of needs that emerge. The health AI technician, specialists who audit AI outputs, maintain the model fairness, and resolve algorithmic conflicts. Okay, what's the physician role in that scenario? It's complex cognition, and that's it. We are liberated from routine cognitive tasks. Our focus is entirely on complex, the ambiguous, and the human. We spend our time on multidisciplinary case conferences, family meetings, ethical consults, and managing high acuity, non-standard cases. We become the chief empathy officer. The time that we save by automation is reinvested in patient connection, addressing emotional distress, building the trust that's essential for adherence and sustained behavioral changes. But what's the strategic challenge here? The primary challenge is not technological, it's societal. What do we do with that displaced workforce? How do we proactively implement massive retraining programs focused on new value-based care roles, data auditing, and human-centered social work to ensure the efficiency gains of AI do not translate into widespread economic disparity? The quadruple aim, I believe, also demands that we protect the livelihoods of our healthcare teams. Not everybody agrees with me on that. All right, here's your second scenario. Community-embedded population health. In this future, the boundaries, the physical boundaries of the hospital dissolve. Healthcare is embedded in the community, focusing aggressively on upstream factors. Here, there's an important partnership model. Strategic public-private partnerships, health systems collaborate with technology companies, municipal agencies, housing, education, transportation, community nonprofits to address the root cause of illness. These are not philanthropic endeavors. They're strategic partnerships that are funded by the shared savings value-based contracts, potentially Medicaid waivers, that allow healthcare funds to be spent on non-traditional services like housing and food. Here you have proactive intervention. Predictive analytics platforms can integrate clinical data with crime rates, pollution index, food accessibility, a patient flag for high risk of diabetes, complications. They don't get another prescription. They get a visit from a community health worker who connects them with a healthy food prescription program and transit vouchers. Here you also have continuous digital monitoring, wearables, in-home sensors, provide continuous passive data streams. So a subtle change in gait, sleep patterns, voice tone, vital signs, all of those things trigger early alerts that allow for pre-symptomatic intervention. And this can dramatically reduce reliance on expensive, late-stage emergency care. In this scenario, you've got an economic shift. The financial model is successful moves from paying for illness to paying for wellness. And the health systems get judged and rewarded not by the number of procedures they perform, but by the percentage of their population that avoids hospitalization. And that changes the entire mission of the healthcare delivery system, transforming it into a community health anchor. The strategic challenge here, though, is around governance with the data and trust. This model requires massive data sharing, clinical, social, commercial. How do you ensure privacy and consent when a patient's health risk is being calculated using their grocery purchases or their housing stability data? The legal and ethical frameworks for this kind of comprehensive data use have to be established with community consent and ironclad security protocols. Before we run out of time, the last scenario, and then I'll wrap up, explores a critical internal threat. I call it the crisis of purpose or the crisis of professional meaning. What happens to a physician's sense of purpose when their routine cognitive labor is totally automated? Well, you see a shift in education. You need new curriculum where medical education moves away from rote memorization towards skills that machines cannot replicate. There are things that we can do and only we can do: ethical reasoning, complex systems thinking, team leadership, cross-cultural communication, digital fluency. Students have to be trained to critique the algorithms, not just trust them. We then have to have students focus on the why, aggressively reinstilling the value of our non-automatable skills, empathy, intuition, things that are developed over years of practice, crisis leadership, the ability to synthesize disparate, contradictory human and data inputs into a compassionate and actionable plan. In this scenario, you have a threat of alienation, where if the transition is managed poorly, physicians may experience this crisis of professional meaning. If an algorithm generates the diagnosis and the treatment plan, do I simply become a high-paid validator? The psychological threat that can lead to a deeper form of burnout called existential exhaustion. But with this scenario, the strategic opportunity is to not see the physician's role as diminished, but to elevate it to the highest form of humanistic leadership. The physician becomes the guarantor of human values in an automated system, the ultimate ethical safeguard, and the translator of complex technology for the patient. The physician's ultimate value is going to lie in the judgment that they render, not the data that we collect and manage. So, 3 scenarios. I really think each of these 3 futures is plausible. None of them are inevitable. The path that we take will depend entirely on how we balance innovation with equity, efficiency with empathy, and ambition with accountability. The future of healthcare will not be delivered to us. It will be designed by us. And that design has to begin with a clear-eyed view of both the potential and the peril of the tools that we're building today. Now, we've been here before. Every major transformation in American medicine, from the rise of antibiotics to the digitization of health records, has required courage, clarity, and a willingness to rethink what's possible. Today, we stand at another inflection point, perhaps the most dramatic one since the Flexner report. It's the convergence of AI, policy reform, and strategic innovation that is reshaping the very fabric of care. We have to become the architects of care. We have to shape our future, recognizing that shaping it will require a completely different type of leadership, not just adaptation, but intentional design. Now, throughout my career, I've held dual perspectives, that of clinician in the operating room, strategist in the boardroom. And during my time as president of the AMA, I learned that policy isn't just paperwork. It's a safeguard for trust. I remember once debating the ethical implications of AI in clinical decision-making, and I pushed back against the idea of algorithms being simple co-clinicians, because I understand that the final accountability and ultimate consequence of error rests with the human physician practitioner. And so I've always advocated for frameworks that demand human oversight, algorithmic transparency, and clinical accountability. At the same time, my journey as a technology innovator with informatics training has shown me the power and the peril of disruption. I have seen how tools can transform workflows, reduce burnout, and improve outcomes, but I've also seen how poorly designed systems can erode trust, widen disparities, and alienate clinicians from the core of their calling. So I've learned to ask not just, can we build it, but should we? And who does it truly serve? And that mindset has guided me in leading innovation efforts, from piloting blood sugar management algorithms in acute care settings to shaping national standards for data interoperability. And those dual perspectives really shape my outlook. Physicians must lead, and not just in the clinic, but in the legislature, in the design lab, in the private sector. We must advocate for systems that serve patients, not just profits. We must demand transparency, equity, and accountability in all of the tools that we use. We must ensure that innovation never outpaces compassion. So, my final slide. I want to leave you tonight with this challenge. A challenge that I think we collectively inherited from Dr. Oliver Wendell Holmes, who used his eloquence to save a national icon. The American healthcare system is our national icon. It is structurally sound, but suffering from decades of fragmentation and complexity. It is now being assaulted by overwhelming data and existential questions of purpose. So, what role will all of you play in shaping the next chapter of American medicine? Will you be a steward of ethical AI, ensuring algorithms we deploy are fair and just? Will you be a champion of equitable access, finding innovative ways to finance care for the most vulnerable? Or will you be a designer of systems that heal not just the body, but the community, using data to bridge the gap between the clinic and the context? Because the future of healthcare isn't written in code or in policy papers, I believe it's written in courage. It's written in the intentional choices that we make today to preserve the human heart of medicine while embracing the exponential power of technology. I'll close by leaving you with a vision. which is that by 2030, American healthcare will be human-centered, data-driven, and equitably designed. A vision where technology amplifies empathy, policy fosters trust, and every patient receives care that is personalized, proactive, and just. Let's come together to write that future. Thank you, and thank you for giving me the incredible honor of delivering tonight's 50th annual Garland Lecture.
Thank you, Jesse. I think we have time for some questions, both from the audience here and from the online audience, if there are any. Mario?
Yeah, thank you. Thank you, Jess, for coming out. It's good to see you again. So I have an existential question. AI clearly is going to lead to advances, but the algorithm maintains that you basically incorporate all the knowledge that's known. And I can see where it'll be of value in an office where if you're faced with a clinical conundrum and you can't figure out what's wrong with the patient, you can think of 6 or 7 possible diagnoses and the AI helps you. But did you think of 8, 9, and 10? And you said, oh, I forgot about those, but I should. And it may give you insight as to how to differentiate between the 10. That's probably the promise of AI. But the fear is that it may even stifle innovation. And I'm going to give you one example. 2,500 years ago, Aristotle wrote what would be considered definitive text on science and medicine. And for 2,000 years, no one questioned it. Things changed with the Renaissance. But if we had a magic AI box in 1400, 100 years before the Renaissance, and everyone became dependent on all the knowledge of the world based on that box, would the Renaissance have ever happened?
So a wonderful framing of a really important question, which I think fundamentally comes down to trust. And I've spent a lot of time in these conversations in Washington with the FDA and HHS. Nobody really knows today what level of evidence should we require to bring an AI tool into clinical practice. That this has been hotly debated. The previous administration had a particular perspective on it. That perspective went out the window on January 20th or whenever the transition happened. And we still struggle. I think it's unlikely in the current political environment that we'll see particularly meaningful help in addressing that question. I think it's going to be left to the larger ecosystem to step in and define when we believe we can trust these tools and use them and at what level. And obviously there's a lot baked into how much risk and what the tools are doing. And what I encourage developers to do all the time is that regardless of what they may be or may not be statutorily required to do to get an approval or clearance or to market a product, there are things that they can do around accountability, algorithm validation, ongoing monitoring, and assessment of drift that goes well beyond what they may be required to do by the federal government, that's going to be required to lead the market and establish the trust of the physician. Great question.
Magdalena?
Thank you for that talk. I have a lot of thoughts, but I'll maybe just ask 2. One of them is, so I teach fellows and residents and medical students, and I happen to think that a lot of times the inefficient system of organizing your thoughts and writing the note and working through that process slowly and laboriously actually helps you learn how to think critically. And so if that sort of exits the clinical encounter, how do we teach people how to think critically so that then they can become those sort of higher order clinical judgment makers? That's my first question. And my second question is, what about developing countries? And how do we integrate globally?
Two questions that are totally on point. I have absolutely no idea what to do with the first. I mean, when I was a medicine intern admitting patients, on call at Mass General overnight, the most important thing I did after, talking to the patient, examining them, was spend the hour writing my admit note, because that's when I had the Word document and I was moving stuff around and trying to organize my thoughts and think through the differential and figure out a plan. And you're right, when you have a tool that's generating 80%, 90%, 95% of that for you, what does that do to our sort of cognitive approach? I have no idea. I think there's some really critically important questions that really come into the medical education space that I think we're going to have to grapple with. And there's literature out there around different parts of the brain that atrophy when you use these tools in different kinds of ways. And Bob Wachter, who's the chair of medicine at UCSF, has written a couple wonderful books. He has another book coming out this spring. I can't wait to read it. But he wrote a piece on de-skilling physicians and what does it mean when you can no longer perform a certain task because you're totally reliant on the technology. And I think we're just starting to scratch the surface of those questions. The second question around sort of developing world where there are not resources, how do we think about improving access and quality and not ensuring that this just makes things even worse for underserved populations? And there's some technical work at a standards level that I'm involved in with the World Health Organization and the International Electrotechnical Commission and others to try to sort of figure out how do we create the infrastructure that can make these tools transportable. And there's some interesting work, I'm happy to share it with you, around how can you create LLMs for everyone else? How can you take foundation models and tweak them, train them, using lower amounts of resources than having to build a model from scratch, but they still work in the developing world. And there's a couple groups in Europe that have done that quite successfully as sort of a proof of concept. The question is, can we scale it by creating the right infrastructure? Yeah.
Yeah. Jim?
Thank you again for such a provocative presentation. I want to ask you about two themes that seem to me are relatively new in terms of guiding the trajectory of medicine. One is the rise of private equity and profit in healthcare, which may be less interested in whether AI will be physician replacement or performance improvement. And the second is the real rise of anti-science and a hostility to the commitment to healthcare as a good. And for example, and again, because you've been involved at a national level, it's my understanding CMS is removing the incentive for screening for social determinants of health. And in fact, as you know, using the phrase diversity and equity and inclusion can have your federal funding cut. Thanks.
Yeah, tough questions tonight. So the attack on science, the discounting of expertise is a very challenging phenomena for all of us. People still do trust their doctor, but there are two problems with that. One is not everyone has a doctor, and that trust is not what it was 5 years ago. And there are tracking polls on this. We know it. I do think that this is a point in time, and we're obviously all watching what's happening around vaccine policy. Pick your point. That's very concerning as we try to practice evidence-based medicine. Ultimately, I think that there'll be a rebalancing, but what it takes to get us there, I don't know. But I think ultimately, patients' humanity is going to demand the things that work and are scientifically based.
Thank you. Noelle, how many questions do we have online?
I'll say
Two? Let's do those, and then Hugh, you'll be last.
Okay, sounds good.
Many comments online about how good the talk was. Some comments regarding patient privacy and protecting data. Is it possible with government oversight regarding health procedures? And is there a difference between state laws, like can governments hack into EMRs and access patient data,
Yeah.
and related to navigating challenges about?
Yeah, the privacy one's an interesting one. In fact, I was talking with the clinical AI lead for one of the nation's largest health systems, private, publicly traded. We'll leave it at that. And he said, look, we won't work with a startup, a vendor who doesn't have a certain market cap because the insurance that they have, if there's a data breach, won't cover our loss. So what that means is if you're not big enough, you can't play in this space, which is very challenging as we're trying to support innovation. That's their first point. The second point is there are a handful of people in America whose data isn't bought, sold, and available for purchase. One is my cousin. He actually lives in Arlington. And ironically, so I just have to tell about Jonathan Finger. He's an amazing guy. He has a PhD in theoretical physics from MIT. Amazing, very bright. He did not go into anything in that field. He was probably like the junk mail king. And his job was literally sending us all the things that we never want to get, but every now and then we get and we buy something. He sent out probably billions of pieces of junk mail in his career. He knows the data game, and he's a computer guy and all this stuff. He does not have a credit card. He understands that if he gives up for convenience, privacy, that it has profound implications for who knows what he does. His shopping history, his data history, where he goes to the grocery, all of those things. So he pays cash, he doesn't fly, and he drives up and down the East Coast when he wants to go places. There aren't too many people like Jonathan, right? Most of us use our, grocery store savings card to save the 30 cents, and then they know who we are. Most of us use a credit card. And if anybody's interested in actually seeing where your data is, there's a website I can point you to, and it's mind-blowing. So we have this illusion of privacy that doesn't really exist. Now, yes, there's nuance in our health data in general is not available for sale. But there are a lot of inferences that you can make about your health conditions, diseases that you have based on publicly dated consumer level information. So what does that evolve into in the future? I think there is growing concern around data, how the federal government's using data, how the data is being accessed, who has access that we saw at the beginning of the administration. I don't know where that translates in the future, but I think you have to recognize what the current state actually is as we sort of enter into those conversations. Great set of questions online.
And then another set of questions online regarding your call to action. Is there a path to use the profit motive to get to that goal?
I think there's, and I forgot, didn't ignore the question about PE earlier. PE is not good, it's not evil, it's just a tool, right? And it's a structure and it's an incentive that sometimes does really powerfully good things. In other cases, it causes chaos. And we've seen PE come into certain specialties and exit when there's nothing left. It's kind of like the Giving Tree, if you ever remember that book. In some circumstances, there are other examples, some might say fewer, where there's been a tremendous societal good from sort of PE transactions and other things. I think ultimately it is about the alignment of incentives. But for us, I think we have to go in to reimagine what is possible using the tools that we have to do that. Thanks.
And the profit motive issue? Somebody asked about, could the profit motive drive us?
I mean, I think the profit motive is, it's good and bad, and it comes back to that issue of around alignment incentives. Yeah.
Thank you.
Thanks, Jesse, for a very thought-provoking.
Thanks for being patient.
talk. My pleasure. So I'm a family physician. I've spent my career, building trust with patients, which I think, as you say, is crucial. The part of the AI revolution that I'm confused by is the role of, physicians or possibly nurse practitioners, PAs, in actually, interfacing with patients. My experience certainly has been that most patients are looking for a person they can trust. I keep hearing about patients who may feel they can interact with an algorithm online, with AI online, and get information. I think most people at some point will want to contact a provider, a real human, to see how they are on the right track.
Yeah.
So my question to you is, do you see as AI gets going, do you see that changing in terms of the kind of interactions that patients will want to have with a real human?
Yeah, I think it shifts. I think there are a certain set of interactions that we probably just see evaporate. They can be handled by pathways, technologies, algorithms that is probably fine. There are other interactions, like when I'm really sick and I want somebody to put their hand on my shoulder and tell me it's going to be okay, right? And you can't replace that with an algorithm. But I think the work changes, and I'll share a perspective on this. The first FDA-approved autonomous clinical AI device. Does anybody know what field it's in or what disease? Any takers? Diabetic retinopathy. It's this really cool system. It's like the size of a large microwave, developed out of a team spun out of the University of Iowa, ophthalmologists, really brilliant folks, where they developed an AI tool, and somebody with a high school education can put a patient in front of this thing and get really good pictures of their retina and screen for diabetic retinopathy. And as everybody here knows, every diabetic patient ought to get a screen every year. How often do your patients get their diabetic retinopathy screens?
I sent them to Dr. Liao. And
Yeah,
she
and
does
then
everything.
I'll take care of. So we don't have enough Dr. Yaos to do that. We just don't, right? So we now have the capability, we've had it for 5 years, to screen every patient globally for diabetic retinopathy. Now that hasn't exactly happened because the company hasn't really diffused the technology, but theoretically you could put them in your office, put them in a Walmart, put them anywhere, right? And do the screenings. And then suddenly our ophthalmology colleagues are only seeing the patients with the disease. It changes when you step in, when you need it. You change the work, and I think that's okay. But at the same time, if you don't have enough interactions to establish the trust, how do you have that trust when you really need it? And, a lot of debate around like vaccine and vaccine access, and if kids are getting vaccinated at Walgreens, does that mean they're not seeing their pediatrician? Well, it turns out my Walgreens won't vaccinate kids because I've tried to take my kids there for a COVID shot. And so like they're out of that game entirely. But you get the idea. It's the same thing, our health system turned on in the EMR filtering of sort of like pleasantry messages in your in basket. So if someone says, hey, happy birthday, or congratulations, or nice to interview on TV, I don't see those messages. They just get filtered out. Now, does it save me some time? Sure. Does it change my ability to create that interaction with my patients, that relationship? Absolutely. So I think we're entering a new era. We'll have to navigate it together. But I hope that everyone here takes away a theme, which is that at the core of the profession and our future as physicians is the humanity that we bring to care. Thanks.
Thank you.
Thanks. Thank you, Jesse. So this program is approved for 1.5 CME credits, free. Fill in your survey and UMass Chan will award you your credit. We also have a program on November 7th honoring the 150th anniversary of the BML. I hope everybody will attend this program. Thank you very much for coming. Thank you, Jesse.